Good morning, everyone. So I will be presenting tips and tricks of managing corneal and corneoscleral tears. So the first video, one should not do this. The iris should not never be reposited from the same site of the wound. Always create a different site port and then reposit the iris. In such cases, if you feel that the iris tissue is devitalized, remove it. Take the first suture at the cardinal points, at the junctions, the lacerations or the V points, so that the wound is restored, and then proceed with the further suturing. If you have a wound like this, which is very irregular, in such cases, interrupted sutures many a times don't work. So you need to take the cruciate sutures so that to store the integrity, and later on the interrupted sutures are used to fill the gap. If you have a wound like this in which there is infiltration, always repair the vertical part first so that the watertight compartment is restored, and then take the long bites away from the infiltration part. In this case, it was just like a pseudocornea, so we didn't try to remove the vitreous and the iris, and later on, through the pars plana route, the lens and the vitreous was removed. In this type of an injury, first remove the iris tissue, take the cardinal sutures at the limbus, and then try to move posteriorly. In cases of the scleral tear, you start anteriorly and then move posteriorly. And then to fill the defect, the cruciate sutures were taken and the wound was closed, and later on, the wound was explored, the scleral tear was explored posteriorly, and it was sutured using 80 Vicryl. In this case, after doing the conjunctival peritomy, because it was a scleral tear, it was closed using 80 Vicryl, and the tear was suspected behind the muscle also. So in this case, first take a stay suture, resect the muscle, and then suture the tear behind the muscle, and later on that stay sutures are used to reposit your muscle at the place. Thank you.
Thank you, Dr. Shilpi. Some very interesting points that came up from this presentation, that when you have a corneoscleral laceration, in that case, the first suture has to be passed at the limbus, because that is one tissue wherein you can just oppose the white line so that you have a good configuration. There are two schools of thoughts in corneoscleral laceration. One school of thought says that the corneal suture should be put first, the second says scleral first. Majority believe that the corneal suture should be first put, and then you go behind in the scleral area, and very nicely pointed out that if the perforation is behind the muscle, then you have to first cut the muscle and then repair and then reposition it. Of course, you put the sutures first. And if it's just adjacent to it, then you can hook the muscle and go behind and then suture it. One very important point that came up was that when you are doing a corneoscleral perforation repair, you should not reposit the iris tissue through the main perforated area. You should make a side port incision, then inject viscoelastic, and then reposit the tissue. So a couple of very interesting things that came up, and we all have to remember that. Any other point, any comment from anyone? Yes, Abhinandan. When do you go for the secondary intervention means?
So after 10 to 14 days.
Or a vitreous hemorrhage or anything.
So vitreous surgery,
Yes.
we usually intervene after 10 to 14 days.
We would like to do an ultrasound, see whether there is a retinal detachment or not. If there is a retinal detachment, then
As
of
early
course
as
we have to
possible.
do it as early as possible. Another point that I would like to add here is that if there is any tissue defect, we should not just crumple the corneal tissue by putting sutures. We should first try to oppose the tissue properly. If there is a defect, we can put a glue over the surface. If it's not working with glue, we have done a few tectonic grafts, corneal grafts in such cases, wherein the tissue defect has been quite large. Wait for some time. Yeah.
But in case we have a corneal foreign body and it requires an intervention, then and it's a corneal wound which is eccentric. It's not in the center. The visibility permits. Then at times we make a decision to do it at the same time, though usually one waits.
I think for prophylaxis, I don't know whether intravitreal antibiotic should be given. Intracameral has been given. I would like to have the opinion of, yeah, the retina people, that whether you would like to give intravitreal. Yeah. Hmm. What about intracameral antibiotics? Because if there is nothing in the vitreous cavity, why to put intravitreal injection? Intracameral antibiotic has a proven role in studies also to, take care. Yeah. Yeah, there are studies which have shown that in a prolonged, iris prolapse with perforation with prolapse, intracameral antibiotic has a role to play. Mhm. Okay, that's that. Along with, along with
Vancomycin.
vancomycin. Okay, that's a wonderful point.
The
Yeah.
only thing which is happening these days with ceftazidime is in India there's almost about 80% resistance to ceftazidime, and that's what the LVP study is showing now, and they are moving into imipenem.